How many of you know how many types of optic disc pit exist in human race? Anyone? Think about it until we reach the end. So, by our classification, there are 4 types of optic disc pit. Type A, where optic disc is open and they get the serous macular detachment. Type B, where the serous detachment is present but optic disc pit is closed involutionally. Type C, where optic disc pit gave the macular hole and optic disc pit is closed by the vitreous incarceration. Type D1 and D2 occur after the surgery. When you peel the ILM, they get the macular hole and they gets open most of the time. And sometimes you plug the pit and later on from the serous macular detachment, you get the macular hole. So it's mostly, so when we say that every pit has the same method of treatment, I disagree. Every pit deserves his own treatment. So I will share with you few of my. So this is how we name the type A. Here you can see optic disc pit and serous macular detachment. So this is the preoperative OCT. You can see the serous detachment of about 2000 micron meter. And here I will show you the surgical procedure. So we plug the pit with the plug, and we have a series of more than 30 cases with the different techniques. Here you can see the posterior highlight shape in the type of cisterna. I stain it with a triamcinolone that I usually do. Here you can see the clearly the optic disc pit and serous detachment. This is a punctum plug that I use to close it. Here I am opening the punctum plug at the cornea and then getting it with the end grasping forceps. After getting it with the end grasping forceps, we go inside the vitreous cavity and you plug the pit. Unless you don't plug the pit, your serous detachment is not going anywhere if this pit is functional. Just keep it in mind. So here you can see the plug is with the end grasping forceps and I am aiming the optic disc pit. So you should be focused, you should be managed to get it inside the pit. So there are different sizes of pit sizes and different sizes of plug sizes. So you have to do the OCT to measure the pit size and then adequately you have to choose the punctum plug size. Here you see I put this plug in the optic disc pit and then just little bit push it. So at the end of the surgery, you can see the pit is closed completely with the optic disc punctum plug. So here are the post-op images. In the post-op images, you can see the punctum plug is lying in the optic disc pit, and this is the shapes and parameters of punctal plug. These are the post-operative fundus images. Here you can see the punctal plug is nice, serous detachment is going, and this is after 4 months of this treatment. Patient from the counting finger reached up to the 6-9. We are following this case from last 9 years. So this was our first among the first few cases. So I have a short of time, so I will quickly go for type C. That is very interesting rather than type B. In type B, you can just do the vitrectomy and you can get rid of it. Here is the optic disc pit and full thickness macular hole. So this is very challenging, and here you can see the preoperative OCT. And it's the very and can I have 1 minute only? So I just want to share it because it's very rare condition, and you hardly will see in any book or any video or anyone has ever seen it. So here I'm doing again the vitrectomy, and I will just be quick. Triamcinolone, the same one. Same pattern of posterior highlight as it's shown in the previous video. And then here I stained the posterior highlight and stained the ILM. Here I'm removing it. Very interesting thing is that here you can see the posterior highlight is plugged in the optic disc pit. This is one of the rarest conditions that ever been seen, and it is not mentioned in any literature till the day, to my knowledge. And this optic disc pit gave the serous detachment, and then serous detachment converted into the macular hole. And here you can see how tightly it's fixed. Even with the maximum vacuum, I cannot break this vitreous. out of it. So at the end, I did the temporal flap, and we got macular hole closure. Maybe someday I will have more time and I can explain it in more detail. Thank you so much for having me.
Thank you, Dr. Hussain, for this nice video. And I just have one question.
Yes, please.
We do the plug with amniotic membrane, with your technique, with also ILM, but we don't do a visual field, neither before, neither after. And we see the OCT that show the anatomic changes and improvement, but actually we need a study to show that the manipulation of this area, does it affecting the visual field? What do you want to say?
Yeah, we
about that?
have already published this recently. The first thing is, if you go to the optic disc pit is crowded by glial tissue. It's not a neural tissue. Excavation is by the glial tissue, so you are not harming any neural tissue, one thing. Second thing is that this plug is a flexible silicone plug. It's not putting any pressure. Third thing is the issue about the visual field. We are doing the microperimetry of all these patients and visual field. We don't have any neurological effect. Last thing is, you mentioned about the amniotic membrane and ILM flap. I demonstrate every time. So how the ILM flap can close a optic disc pit. This is weird. How, if the fluid is coming from optic disc pit, how the flap can control the fluid coming out. How the amniotic membrane can do. You have to have something that is closely tightening it. So if you have a 10 seconds, I can demonstrate how it works. So here is the optic disc pit. Yeah. So this is your ILM flap. You are closing this hole. Yeah. Am I right? That's question. See. Does it close? No. Can't close it. Your amniotic membrane. Close? No. So you need at least something that is closing it like it. So see. No flap. Nothing. So see, you need a plug. That's the simple. No rocket science. Believe.
It's nice to show it, Dr. Hussain. Also, sometimes creating another hole, evacuating the amniotic membrane, can decrease and create a circle to avoid the plugging. So this is another way to close it.
Actually, there's a lot of things that are still mysterious. My 30 cases, I found these 5 times. Maybe I beat the 100 cases in next 30 years, maybe. Because you get hardly one case in 1 year. It's not, I didn't read this type C, never in the world. So I thought 30 cases, maybe I get 30 more, maybe I find some new. Till the day we have only 4 types that we discovered. Otherwise, literature what explains? Optic disc pit, do the amniotic membrane, do the AMG, doesn't work. Oh, my case worked because you have done only 1 case in whole life. My failure rate is 0 because I did 1 case. Obviously, 100% success rate in 1 case.
Okay. Thank you very much, Dr. Khaqan. Thank you very much. Next presentation is by our moderator, Dr. Abdullah Qahtani, Retinal Hemangioma Management.
Thank you.
Okay.